Welcome to Heart Failure Unfiltered. My name is Nick Hartshorne-Evans, and I'm the founder and CEO of the Pumping Models Foundation, the UK's heart failure charity. Today, we'll be discussing Beat HF Simple Wins, a podcast about heart failure and why the simplest ideas often save the most lives. This podcast asks one question over and over again. How do we make heart failure care so simple that it actually gets adopted? Because if care isn't adopted, it doesn't matter how clever it is. So how do we make heart failure care so simple it actually gets adopted? Clinicians are overwhelmed, patients are exhausted, systems resist complexity, and behaviour change only sticks when it's obvious. Is it complex or simple? Too many tools, too many thresholds, too many pathways, not enough clarity. So one simple Beat HF principle, one acronym that matters, one action that helps, one moment where timing changes outcomes. No dashboards, no jargon, just one thing to remember. So with me today at the Liverpool Podcast Studios, I've got...
Hi there, I'm Claire Taylor. I'm an NHS GP and Professor of General Practice at the University of Birmingham.
Hi everyone, my name is Dr. Rajiv Sankanaran. I'm a consultant cardiologist in Liverpool.
Hi, I'm Fozia Ahmed, Dr. Fozia Ahmed, a heart failure cardiologist based in Manchester.
So we've got an esteemed panel here. So we're going to be talking about heart failure, obviously, and heart failure is full of good intentions, guidelines, pathways, scoring systems, risk stratification tools, and each one makes sense on its own. But stacked together, do they overwhelm the very people they're meant to help? So I suppose the question to throw out to start this session is the problem we've over-engineered heart failure? Who wants to take that?
I don't mind kicking off. Just, I think I agree. We've perhaps by over-engineering it, overcomplicated it, but there still needs to be some degree of structure and framework that's common across cities, institutes, countries in which to frame heart failure. So maybe just like a blueprint for what heart failure is and how to communicate it and how we treat it. But yeah, you're right. I think sometimes as experts, we go so deep into a subject that we can, without realising it, overcomplicate it for people who are new to it.
Do you think we sort of, we go so deep into that channel that we realise that outside of that channel of thought process, that everybody else needs to understand this?
Perhaps, yeah. But I think one of the nice things to do is sometimes in clinic a patient will say, actually, I've not understood a word that you've said. And then it reminds you that actually I'm speaking a totally different language, using medical phrases, jargon, academic language, acronyms. And none of that's been socialised with the wider population. So actually we do need to strip it back and have a universal form of communication that is easy for everyone to understand.
What do you see, Claire, in primary care? Do you?
I mean, heart failure is a clinical syndrome, so patients need to have symptoms of heart failure, signs of heart failure, and then we need to do tests to work out if they've got a structural or functional heart abnormality. And I think the awareness around heart failure being this syndrome where you need all of these things is actually quite limited in the general public, amongst patients, amongst families, communities. And as primary care clinicians, we see the full breadth of disease from newborn babies through to end-of-life care. And I think as primary care clinicians, we're aware of heart failure as a clinical syndrome. We're aware that it's a common condition, but it often coexists with lots of other conditions. So patients that we see in primary care are actually quite complex. They don't come into us saying, I think I might have heart failure, partly because of that awareness thing that I think heart failure, the key symptoms of heart failure as a disease is just not well known about. And that's partly why we're here today, to talk about that and try to raise the awareness of the symptoms so people can recognise the fact that if they feel breathless, if they feel tired, if their ankles are swollen, I can't remember the last time somebody came in to see me as a GP with those things and said, I think I've got heart failure. So I think
Do we just not think of heart failure straight away? Is it like it's the last thing that we think of?
I think you think of other things first, and I think that's probably reasonable because most people walking through the door of a GP surgery with breathlessness or tiredness, they probably don't have heart failure because there's a lot of other things that cause the symptom of breathlessness. But I think if that person comes through our door a few times with those symptoms and the things we've tried, treating for a chest infection, optimising their inhalers, if they've got asthma, looking at anxiety, if still they're coming to us with those symptoms, we need to be thinking about heart failure. And I think that's where the challenge is at the moment, is that patients have often come to us multiple times, and unless we as clinicians in primary care think, could this be heart failure, and do a simple blood test to find out if we do need these further more complex specialist tests, then we're never going to make that diagnosis. And
that rings true for me, being a patient advocate for so many years. I hear that all the time. But Rajiv, is that a challenge within the whole conversation that that maybe we're overcomplicating it, or does it just live in our sort of world of specialism?
No, I think there's a pressing need to simplify it both for patients and for clinicians. And that's the problem. If you introduce too many hurdles and overcomplicate things, there's that loss of clarity. The pathway does not become seamless. There are multiple visits that a patient needs to make for investigations, for treatments to be started. So it's to ensure that there is clarity throughout the pathway, make sure that the number of visits for investigations and treatments to be initiated, they're minimized, keep it as low as possible, and ensure that all the clinicians who encounter patients with these symptoms, like Claire was saying, it could be in primary care, it could be in secondary care, are aware of what this pathway is. It's pretty standard. So many of the tests and the treatments that have been used for heart failure, they've been around for several years. So I think there's this danger of overcomplicating it and making it too specialized as well, and thereby delaying patients' access to treatment. It's like having too many VAR reviews in a football game, lots of stops. So there's that flow that goes in a pathway, for example.
So we're here to talk about BEAT. So many years ago in Birmingham, we tried to figure out an acronym, and Claire put a finger on it rather than using mine, which I always relate to because it wasn't very acceptable in the NHS. I can't say that, else we'd have to have a bleep. So what does BEAT stand for, and what were we trying to achieve, Claire, with BEAT?
Yeah, so I think that, you guys as patients and me as a GP had really recognised this huge issue of symptom awareness for heart failure. So in other conditions, patients, the public, healthcare professionals are very aware of those key symptoms that might suggest a certain diagnosis, like FAST for stroke, face, arm, speech, time to call 999. That's been a very successful campaign to raise awareness of the key symptoms of stroke and what you need to do about it. Call an ambulance. And so we were sitting in Birmingham trying to work out how we can create an acronym. And we thought, what are the key symptoms of heart failure? So breathless, exhausted, ankle and leg swelling. And then what do? We need to tell people what do you do if you recognise those three key symptoms. So it's T, time for a simple blood test. And I think the simplicity of that acronym has really carried us forward, because it's something that I think resonated with people who we then took it to. We talked about BEAT more, and people went, yeah, when I'm presenting it at talks or conferences, you can see the room, people, yeah, FAST for stroke, that's really worked. BEAT for heart failure. Hopefully we can really do the same, because at the moment, heart failure is just diagnosed too late, and that prevents patients receiving the life-saving therapies that can help them to live well with their heart failure. And what we need to do is have that awareness out there in the public, so that patients, but also family members, can recognise those symptoms if the patient themselves doesn't realise, which they may not, because the symptoms can creep up gradually. It's that mother, father, daughter grandchildren who can say, yeah, you know, Nan's been breathless. She's more breathless. She can't do the things she used to. And she's so tired and her legs have really swollen up. We need to see the GP. It's time for this simple blood test, because it's a blood test we can do in primary care like any other blood test. And if it's raised, that tells us that we need to refer for further investigation. So normally an echo, a heart scan, and a specialist assessment to confirm or rule out the diagnosis. But that blood test is really, really key to that pathway. And unless patients come to see us with those 3 key symptoms, and we as clinicians think about those key symptoms and the time for test, then we're never going to get that diagnosis. And the diagnosis is the key to everything else. Without that diagnosis, patients can't get these life-saving therapies.
Can I pick up on that?
Yeah, absolutely.
I love what you've said, and it really resonates, because actually, if you think about it, the public awareness about cancer, about if you've got blood in your stool, go to see your GP. If you're losing weight, could it be a malignancy? Public awareness about heart failure is low, and I think just having these simple acronyms like you describe help people to know what are the nudges when they should seek assistance. So I think it supports building a community of awareness.
I like the word nudges.
Yeah, pushing you in the right direction, meant to advance people, push them towards seeking medical attention.
That word nudge is a really cool way of describing it, really, because we're not pushing the people saying that it is heart failure, but it's a nudge towards think it could be heart failure. Therefore, what do we need to do to rule out heart failure?
Yeah.
And it's not just the public, but even to, like I said, the wide
Medical
the range of professionals, clinicians that these people can encounter. It could be pharmacists, could be practice nurses. So it gives something very tangible. So there's the symptom awareness, but what do you do if they have those symptoms? There's a simple blood test, and there's that inherent positivity in the message. Be it's a condition, if diagnosed, it can be managed, it can be treated.
Failure.
Exactly. So it brings everything together into a simple message.
Totally. And I think there is a need for greater public awareness. It used to be the case that 1 in 5 people will develop heart failure during their lifetime. It's now increased to 1 in 4 people. So actually this is someone, if we're sitting in the room here today, we know that 1 in 4 people sat here will have been affected by heart failure.
I think I've taken that spot.
Yeah, or know someone who's had heart failure in their family. So if you think about our family structures, it's mission critical to the survival of your family and your immediate community that you've got awareness and you've got people who are aware of what heart failure is.
So I suppose this BEAT is something that, or acronyms, you can use it where a patient explains to their partner what it is and the partner automatically gets it. A nurse can use it, whether in the community, in a GP surgery, in a hospital, whatever, they can use it and it's there at the top of the head. They use it in a busy shift. I think the big question for me is it deployable within the NHS or is it deployable in the health system? There's a lot of real positivity about it and adoption, and people like it. Not just heart failure specialists, but a wide variety of people, and internationally as well. It's recognised, obviously in English-speaking countries, Canada, for instance. But is it deployable? Are we wasting our time? Or is it deployable?
I think so. Definitely, yes. I think the simplicity is the absolute key to it. And I think there's a variety of ways that we can deploy BEAT across healthcare systems, both in the UK and globally. And I think that sort of spread of it as an innovation can be quite natural. We can do things to help that. But I think, just talking about BEAT today and raising awareness, and the BEAT HF campaign that Pumping Marvellous has run through a variety of media has really helped just to get the BEAT message out there. But I think for different audiences, you probably need different approaches. So, for example, in primary care, I think just having BEAT as an acronym helps to have it on our minds when we see in patients, both if I as a GP sees somebody coming in who is breathless, but also if our practice nurse is doing perhaps a long-term condition review with somebody with type 2 diabetes, and they might notice their ankles are swollen or they're more breathless than when last time they saw them 6 months ago for their checkup. If our nurse can think, oh, breathless, then she might say, are you really tired? Are you exhausted? Are your ankles swelling up? And if there are those key symptoms there in somebody who's already at risk because of their type 2 diabetes or other long-term condition, then she can say, let's do a simple blood test. So a natriuretic peptide blood test done in primary care, if it's above the threshold, which for NT-proBNP is 400, then we need to refer through the pathway. There's a very well-defined pathway to get an echo and specialist assessment, but it requires that person seeing the patient to think about the symptoms and then arrange the blood test either themselves or speak to the duty doctor to say, this patient's not right. Can you see them? Can we organise this blood test? And that's the really critical part of the pathway that can really then unlock the diagnosis.
So it's like an interest that should, sorry, Rajiv, go on.
I was just saying, I think that's particularly relevant because in primary care, you were saying, so heart failure is one of the conditions that you encounter amongst many, high blood pressure, diabetes, COPD, and it gives you that sort of hook and say exactly sort of makes you remember, through a mnemonic, an acronym that breathlessness, yes, but one of the causes could be heart failure and what you can test for. And likewise, not just clinicians, even for patients in the public. So with breathlessness, you have the misconception, it could be lack of fitness, it could be aging, but then if you don't have one of the causes as heart failure, and it's not just one of the possible causes, it's a cause which can affect mortality, quality of life. So the seriousness comes in as well. So I think it's it brings it together for both sides, the public and clinicians.
Yeah. Can I?
Yeah, sure.
Follow on? So I think what you both described really nicely is the universality of it, that it can be used at every level, whether you're a member of the public, a patient, a healthcare professional or a consultant in clinic. I use it all the time as a structured framework to be able to describe it to patients so that then actually when they're diagnosed with a condition, you've got these symptoms. And if you get a worsening of these symptoms, that's the time to get in touch.
Yep.
So it can be used not just at the time of diagnosis, but it follows the patient through. If you get a worsening of these symptoms, it's a time for specialist assessment.
So how do we prevent BTHF from dying? Because most good ideas die. How do we prevent that?
I think we can learn a lot from what's happened with the FAST campaign and stroke. So Professor Gary Ford in Oxford came up with FAST as this initially for paramedics to recognise the symptoms of stroke and know that they needed to get people quickly to a centre that could treat them well. And I think talking to Professor Ford, there was this sort of natural spread. I think when it's a good idea and it resonates with people, then things tend to outlive other ideas that can just fall by the wayside. I think we can help that by having these conversations within our particular groupings, so primary care, secondary care, patients. But another interesting area is going out into communities and communities that are not well served, because there are people in areas, particularly underserved groups, so particularly areas of deprivation often have quite bad outcomes from a diagnosis of heart failure from some of the work we've done looking at primary care data. So I think we do need to be going more widely and reaching out to these communities, going to places where these people are comfortable to talk about their heart health, and thinking about how we can raise that beat message in the places where it's most needed, because there are certain groups of people more likely to come and see us in healthcare. But unless we reach out, we're not going to tackle these health inequalities that really exist in heart failure.
But don't people just remember stuff when they need to, when it impacts them? Because we've found that that adoption of like acronyms, these like FAST and obviously fast beat, whatever, they only really utilize them when it affects them.
I think it's a good point you mentioned. So, I mean, some of these things, and again, I was about to make the point about emphasizing the impact of the Pumping Marvelous campaign. highlighting that. And we've got stories, isn't it, where a daughter of somebody heard of this campaign and then
on the radio.
Prompted their dad or relative to go and get
Classic
tested.
FM, it was,
exactly. So the demonstrating the impact of the campaign, and that was a nationwide campaign, isn't it? Several cities, including Liverpool. I think that would bring it to fore as to what it can achieve. The low cost or no cost, we'll practice in a very cost constrained environment. As a messaging system, it's something which shouldn't really add too much public awareness, but also clinician awareness. I think emphasizing both aspects, the impact already demonstrated through rolling this out, and that it shouldn't really add to the costs.
It's interesting what my cardiologist said, John. He said, getting your diagnosis right would be like spotting the zebra in the brown pack of horses. But actually, beat is better deployable in the brown pack of horses than the zebra. Because we're looking for a population tool rather than a specific. I mean, mine was very different. It was viral myocarditis, so it's not atypical. I mean, there's a lot of it, but there's not a lot of it compared to those who have more risk, like post-myocardial infarction, heart attack. See, there you go. I'm going specialist. I should talk about heart attack and uncontrolled hypertension, type 2 diabetes, atrial fibrillation. Because if you've got one of those, you're more at risk. And certainly moving forward in the conversations that we're currently in at the moment around obesity as well. So I think what we're trying to do is have some chats that people can remember. And I think simple is safe, and simple isn't necessarily something that I'd attribute what I do on a day-to-day basis. But it's not because patients are incapable, and not because clinicians don't understand the complexity. It's because clarity travels further than cleverness. So anyway, hopefully we've given some insights into BEAT, whether it's deployable, whether we think it's got legs. We hope it's got legs. And I think what we've learned as a team and at the Pumping Marvellous Foundation and everybody who supports us is that the constant drumbeat of noise is more effective than the big spikes of investment. Thank you.